Hi guys, I'm been shooting this video late actually, but it's important part of disorders of retina ophthalmology, that is diabetic retinopathy. Now let's begin without any delay. So talking about diabetic retinopathy refers to retinal changes seen in patients with diabetes mellitus. With increase in the life expectancy of diabetics, the incidence of diabetic retinopathy has increased, and diabetic retinopathy is a leading cause of blindness in the world. So etiopathogenesis, what is it? So risk factor. First risk factor is duration of diabetes. Very important. It's important to note that after 10 years, 20% of type 1 and 25% of type 2 diabetic develops retinopathy. After 20 years, 90% of type 1 and 60% of type 2 develop diabetic retinopathy, and after 30 years, 95% of both type 1 and type 2 develop diabetic retinopathy, that is invariable development. Next is type of diabetes. Relative risk of developing diabetes retinopathy is higher in type 1 as compared to type 2, and the risk of proliferative diabetic retinopathy is higher in type 1, whereas diabetic macular edema is more common in type 2. So in type 1, the risk of proliferative diabetic retinopathy is higher, and in type 2, the risk of diabetic macular edema is higher. Next is age of onset of diabetes is also acting as a risk factor. That is, the risk of retinopathy in a child with onset of diabetes at the age of 2 years is negligible for the first 10 years. It is after onset of puberty, age of onset is not a risk factor. Next is sex. Incidence of development of diabetic retinopathy is more in females as compared to male. The ratio is 4:3. Then poor metabolic control, that is raised HbA1c, that is conjugated hemoglobin A1, that is adult hemoglobin level, is a risk factor for development and progression of diabetic retinopathy. Hyperglycemia of long duration triggers the onset. Heredity, it's a transmitted as recessive trait without sex linkage, and the effect of heredity is more on the proliferative retinopathy. Next we have is pregnancy, that is pregnancy may accelerate the changes of diabetic retinopathy. Hypertension when associated may accentuate the changes of diabetic retinopathy, and other risk factors include smoking, obesity, anemia, and hyperlipidemia. Pathogenesis, hyperglycemia. Hyperglycemia in uncontrolled diabetes mellitus is the fundamental underlying cause for development of diabetic retinopathy. It's basically essentially a microangiopathy which affects the retinal precapillary arterioles, capillaries, and the venules, and these are produced by hyperglycemia. Mechanism is basically chronic hyperglycemia produces microangiopathy. Include first mechanism, which is change in retinal capillaries. Hyperglycemia produces damage to the endothelial cells and loss of pericytes and thickening of the basement membrane of capillary by following. First is sorbitol accumulation in the cell due to aldol reductase mediated glycolysis. Second is advanced glycation end product accumulate in the cell due to non-enzymatic binding of several sugar to protein, activation of several protein kinase C isoforms, and activation of eicosanoids, nitric oxides, and intracellular adhesion molecules, and excessive oxidative stress to the cell due to excess of free radicals. Hematological and biochemical changes induced by chronic hyperglycemia, which play a role in the development of microangiopathy, include platelet adhesiveness increase, viscosity increase, red blood cell for deformation and Rulix formation, that is clogging together, and destruction of red blood cells, and there's the debris gets clogged together, and serum lipids altered abnormally, that is we can say serum TG, triglycerides, and serum low cholesterol, and basically bad cholesterol, LDL, HDL, VLDL, these lipids get then serum we can see lipoproteins, and serum, yes, these are basically gets altered abnormally. Leukostasis, which is increased due to increase intracameral adhesion molecule 1 ICAM1 expression, this is very important, and fibrinolysis will increase. Effect of microangiopathy producing diabetic retinopathy include first effect breakdown of blood retinal barrier, which lead to retinal edema and hemorrhage, leakage of lipid, weakened capillary wall, which produce microaneurysms and hemorrhages, and microvascular occlusions, which produce ischemia and its effect, like cotton wool spots due to infarct of the nerve fiber layer, and arteriovenous shunts, that is intraretinal microvascular abnormalities. Neovascularization of retina is induced by pro-angiogenic factors such as vascular-endothelial growth factor, platelet-derived growth factor, and hepatocyte growth factor, which are released as a result of ischemia produced by microvascular occlusions. Release of angiogenic factor is also mediated by hyperglycemia-induced oxidative stress, activation of protein kinase C and cytokines, deletion of anti-angiogenic factors such as endostatin, angiostatin, pigment epithelial-derived factor. Then this thrombospondin 1 and platelet factor 4 also play a role in causing neovascularization. Speculated pathogenesis of diabetes retinopathy is basically this. We can see as seen in this diagram. Vascular and hematological changes which are seen in DM cause thickening of capillary base membrane deformation, as we saw the pathogenesis, microvascular occlusion, retinal ischemia, capillary leakage, and then all these things. Now talking about classification and features, basically retinopathy has been classified as non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and also diabetic maculopathy and advanced diabetic eye disease. Talking about non-proliferative diabetic retinopathy, mild grade, moderate, severe, and very severe grade. Proliferative diabetic retinopathy without high risk and with high risk characteristics. So non-proliferative diabetic retinopathy. Ophthalmoscopic features of NPDR include microaneurysm in the macular area, retinal hemorrhages which are both deep, that is dot and blot hemorrhage, which are more common, and superficial hemorrhage, that is flame shape, retinal edema, that is kind of retinal thickening, and capillary leakage and hard exudate, which are yellowish white waxy looking patches. What's important in this is hemorrhage, when it's deep it looks like dot and blot, and when it's more kind of superficial it looks like a flame shaped. Then now talking about here cotton wool spots, venous abnormalities, intraretinal microvascular abnormalities, and dark blot hemorrhage presenting hemorrhagic infarcts. Then early treatment diabetic retinopathy study. These are mild NPDR, at least one microaneurysm must be present, moderate microaneurysm or intraretinal hemorrhage in the 2 or 3 quadrant, early mild IRME. What is IRME? Can anybody tell what is IRME? Intraretinal macular what? Not macular, microvascular abnormalities in hard exudate and cotton wool spots. What are hard exudate? Hard exudates are basically yellowish white waxy looking patches which are arranged in clumps or in circinate patterns and commonly seen in the macular area, and they occur in chronic localized edema, and they are composed of basically leaked lipoproteins and lipid-filled macrophages. These two contents are important: leaked lipoprotein and lipid-filled macrophages. Severe NPDR is 4 quadrants of microaneurysm and extensive intraretinal hemorrhages, 2 quadrants of venous bleeding, and 1 quadrant of irma changes. Very severe, 4 quadrants of microaneurysm and extensive intraretinal hemorrhages, and this is basically 2 quadrants of venous bleeding and 1 quadrant of irma changes. Risk factors are basically these against irmas, then multiple increasing intraretinal hemorrhages, venous bleeding and loops, and widespread capillary non-perfusion. Guys, now you will ask that these all quadrants and thing we can't remember so easily, so for that now you will see the diagram over here. So guys, as you can see this diagram, this is known as basically, as you can see over the first diagram, that is a mild NPDR. That is, what is NPDR? Non-proliferative diabetic retinopathy, right? So this is the mild NPDR. What you can see in this diagram, 1 microaneurysm. What is aneurysm? That is dilatation, right? So you can see over here there is 1 microaneurysm or dilatation which is present. Can you see? This is the 1 microaneurysm or dilatation which is present. Now next is moderate NPDR. Can you see this second diagram? What is here? Microaneurysm, or can you see this microaneurysm or the intraretinal hemorrhages? These are occurring in 2 or 3 quadrants. Like for example, we divide the retina into these quadrants, so you can see this intraretinal hemorrhages in 2 or 3 quadrants. Then there is a early mild intraretinal microvascular abnormalities. These are called as early and mild intraretinal microvascular abnormalities. Can you see this? And you can also see some hard exudate. What are the hard exudate? Those are the yellowish whitey waxy looking patches which are arranged in clumps. Can you see? These are the yellowish white waxy looking patches which are arranged in clumps. So this is basically moderate NPDR. I'm talking about severe NPDR. What you can see in severe NPDR, you can see that basically 4 quadrants of microorganism, 1, 2, 3 and 4. So all the 4 quadrants of microorganism, an extensive intraretinal hemorrhage, 2 quadrants of venous bleeding. Can you see those 2 quadrants of venous bleeding? So this venous bleeding, what is venous bleeding? First of all, venous abnormality like bleeding, looping, dilatation will occur adjacent to the area of capillary non-perfusion. So capillary non-perfusion area पे adjacent you can see venous bleeding. So these 2 areas. Then you can see 1 quadrant of IRMA changes. What is IRMA? Intraretinal microvascular abnormality changes. Then what you see the diagram number D, that is this is a very severe form. Any two of the following, that is 4 quadrants of the microaneurysm and extensive intraretinal hemorrhage. Can you see all of 4 quadrant extensive intraretinal hemorrhage, at the same time 2 quadrants of venous bleeding of course, and 1 quadrant of IRMA changes, but in a more severe form. Then what you can see is basically this diagram. This is known as a early PDR, that is proliferative diabetic retinopathy. We'll discuss this now first and then come to the diagram. So what is this proliferative diabetic retinopathy? Proliferative diabetic retinopathy develops in more than 50% of cases after about 25 years of the onset of disease, and therefore it is more common in patients with juvenile onset type 1 diabetes. So very much important. Next is ophthalmoscopic feature क्या क्या है? So occurrence of neovascularization over the changes of very severe proliferative diabetic retinopathy is hallmark. Very important hallmark is occurrence of neovascularization over the changes of very severe non-proliferative diabetic retinopathy. Neovascularization, character proliferation of new vessels from the capillary in the form of a neovascularization of the optic disc or elsewhere in the fundus, usually in the course of major temporal retinal vessels. So, and this new vessel will proliferate in the plane of retina and spread into the vitreous as the vascular folds, fronds. Okay, and thus result in the formation. So can you see now in the diagram, these are the vascular frond. This is basically the optic disc we can say, and we can say this is the vascular dilatation, proliferative new vessels which have more fibrovascular core, we can say more fibrous, that we say is a term is there for it. The term is called as cicatrization, we can see, or scarring, and more kind of vascular fibrovascular proliferation we can see. Neovascularization we can see on the temporal side. We can see some kind of vascular fronds on the temporal side. So this is the complete picture of early proliferative diabetic retinopathy. Next is fibrovascular epiretinal membrane. What's that? So basically fibrovascular epiretinal membrane is formed due to condensation of the connective tissue around the new vessels. So that's a fibrovascular epiretinal membrane. Can you see this is retinal epiretinal membrane fibrovascular, and next is vitreous detachment and vitreous hemorrhage may occur also in this stage. Types are basically high risk character diabetic retinopathy. PDR can be classified as the PDR without high risk characteristics, characterized by early NBD or NVE, neovascularization, epithelium, and then PDR with high risk characteristics are as follow, that is NBD. What is NBD in this case, guys? NBD is nothing but we can say the neovascularization of optic disc, and NVE is neovascularization not optic disc but elsewhere. So in high risk characteristic you can prominently see the neovascularization of optic disc, that is less than 1 quadrant of the optic disc area with vitreous hemorrhage or preretinal hemorrhage. Then neovascularization disease of optic disc 1/4 to 1/3 of the disc area with or without vitreous hemorrhage or preretinal hemorrhage. And neovascularization of elsewhere more than half of the optic disc area with vitreous hemorrhage or preretinal hemorrhage. You can see in this diagram This is basic early stage. Then you can see this F wala diagram, high risk. That is what you can see. ऑप्टिक डिस्क एरिया में न्यूवास्कुलराइजेशन है, विट्रस हेमोरेज है, एंड एट द सेम टाइम द प्री रेटिनल हेमोरेज इज ऑब्जर्व्ड ओवर यर, विट्रस एंड प्री रेटिनल हेमोरेज, एंड हाउ इट कवर्स दैट मोर देन हाफ और मोर देन half to one third or less than one fourth quadrant. That's the matter. Next is the diabetic maculopathy. Changes in the macular region need special mention due to their effect on vision. These changes may be associated with non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. Clinically significant macular edema is basically early treatment retinopathic studies. This ETD-RS is diagnosed if one of the following amongst the three criteria is present: thickening of retina or within 500 micron, hard exudates and development of zone of retinal thickening 1D diameter or larger in size, or at least a part of which within a 1D diameter foveal center. Clinico-angiographic classification of diabetic maculopathy. How is it? First is focal exudative maculopathy, characterized by macroaneurysm, hemorrhage, and well circumscribed macular edema. And we can see basically macular edema and hard exudates which are arranged in a sarcinate pattern. Then is fluorescein angiography. What it will reveal? It will reveal the focal leakage with adequate macular perfusion. Then diffuse exudative maculopathy. It is characterized by diffuse retinal edema and thickening throughout the posterior pole with relatively few hard exudates. Fluorescence angiography reveals the diffuse leakage at the posterior pole. Ischemia maculopathy. It occurs due to microvascular blockage. Clinically, it is characterized by marked vision loss with microaneurysms and hemorrhage, mild or no macular edema, or very few hard exudates. Fluorescence angiography shows areas of non-perfusion, which in earlier cases are in the form of enlargement of foveal avascular zone. Later on, areas of capillary dropouts are seen, and in advanced cases precapillary arterioles are blocked. Then fourth is mixed maculopathy. In it, combined feature of ischemic and exudative maculopathy are present. So these and these combined features are seen in mixed maculopathy. What is ocular CT scan examination diabetic macular edema classification, in which we are basically first is non-tractional diabetic macular edema, spongy thickening of macula more than 290 microns, cystoid macular edema, then neurosensory detachment with or without A or B. Tractional diabetic macular edema, vitreofoveal traction and taut or thickened posterior hyaloid membrane. What is to note that the OCT classification bearing on the management says non-tractional DME is treated conservatively, whereas tractional DME is purely treated by pars plana vitrectomy with removal of posterior hyaloid. Next is advanced diabetic eye disease, end result of uncontrolled proliferative diabetic retinopathy marked by complications such as persistent vitreous hemorrhage, tractional retinal detachment, rubeosis iridis, and neovascular glaucoma. Next is burnout or involutional stage of diabetic retinopathy, that is proliferative diabetic retinopathy once vitreous contraction complete and tends to enter the burnout or involution stage. Now let's talk about the management part, guys. Management part is very important. This is the diagram of focal exudative diabetic maculopathy. In management, first we will start with screening. How to screen? Periodic follow-up important. First examination 3 years after diagnosis of the type 1 diabetes mellitus at the time of diagnosis of type 2. Earlier, there is no diabetic retinopathy or there is mild NPDR. Every 6 months in moderate NPDR, every 3 months in severe NPDR, and every 2 months in PDR with no high risk characteristic. Investigations in case of diabetic retinopathy: urine examination, blood sugar estimation, renal function tests like serum creatinine, blood urea, and 24-hour urinary protein. Then lipid profile, hemogram, glycosylated hemoglobin, and fundus fluorescent angiography to elucidate areas of neovascularization, leakage, and capillary non-perfusion. Optical coherence tomography to study detailed characteristics, structural changes in diabetic maculopathy. Metabolic control of diabetic mellitus and associated risk factor. It is the first and foremost important to stabilize DM metabolically. Not only the blood glucose level, be in normal range, but other biochemical care parameter is control of glycemia, control of dyslipidemia, renal function test, control of associated anemia, that is target hemoglobin needs to be more than 10 milligram percentage, control of associated hypertension, lifestyle changes. Talking about treatment, first is intravitreal anti-VEGF drugs. Drugs like this, bevacizumab, remdesivir, will lead to improvement in vision. In 40% of cases, 0.1 ml vehicle. Drug should be preferred over laser therapy, particularly in patient with focal CME. That is, what is CME? Correct, chronic macular edema or cystoid macular edema, basically involving areas center of fovea. Then diffuse diabetic macular edema with neurosensory detachment, and anti-vascular endothelial growth factors are also recommended before pan-retinal photocoagulation therapy in patient with PDR and diffuse. What is PDR? Proliferative diabetic retinopathy and diffuse diabetic macular edema. Effect of anti-VEGFs last for 4 to 6 weeks and frequent injections are warranted. Intravitreal steroids like triamcinolone acetonide 20 mg is another drug which is effective and restores the inner retinal barrier. However, the risk of glaucoma, steroid and induced cataract, increased vulnerability to endophthalmitis restricts its use. Thus, anti-VEGFs are preferred over intravitreal triamcinolone acetonide drugs these days. So can you see, this is basically the protocol for laser application in diabetic retinopathy. First you have to do the focal treatment, then you have to go for the grid treatment. That's the focal treatment, grid treatment, and that's the third one, which is known as a pan retinal photocoagulation. This forms the basis of the laser therapy, as you can see over here. And then talking about indications for photocoagulation, that is pan-retinal photocoagulation. Proliferative diabetic retinopathy with high risk characteristics, as we saw over here, the high risk characteristic, these characteristics. Then we have basically neovascularization of iris and severe NPDR associated with poor compliance for follow-up before cataract surgery or yak capsulotomy, and renal failure one-eyed patient in pregnancy. Then also a shot of anti-VEGF intravitreally given before PRP may protect the macula as well reduce the risk of vitreous hemorrhage, and further intravitreal steroid may be considered as an adjunct to PRP. Surgical treatment is indicated in these cases. Which cases? Fractional diabetic macular edema with non-proliferative diabetic retinopathy, and treatment of choices pars plana vitrectomy with removal of posterior hyaloid. Next is advanced proliferative diabetic retinopathy with dense vitreous hemorrhage. What is this? PPV? Again same, pars plana vitrectomy along with removal of opaque vitreous gel, and endophotocoagulation should be done at early stage. Advanced proliferative diabetic retinopathy with extensive fibrovascular epiretinal membrane should be treated with pars plana vitrectomy and along with the removal of fibrovascular epiretinal membrane and endophotocoagulation. And advanced proliferative diabetic retinopathy with tractional retinal detachment should be treated with pars plana vitrectomy and endophotocoagulation, detachment of detached retina along with other methods like scleral buckling and internal tamponade using intravitreal silicone oil or gases like sulfur hexachloride or perfluoropropane C3F8. Okay guys, so that was about diabetic retinopathy, one of the most important topics included in disorders of retina. As I had promised that today I'll post a video of retina, so this is what it is. And there is a small homework for all you guys to find about YAG laser capsulectomy procedure, that is what is ND and YD YAG lasers. Just check out about it and surely comment below if you complete your homework. Thank you.